Well, good evening, everyone, and welcome to it's the fourth webinar that the European DBTA Association is organizing. My name is Jan Hilbig. I'm a psychiatrist and psychotherapist. I will be moderating this webinar, and we are very honored to have a special guest, an expert of his field tonight, Lars Mehlum. He will give a webinar on how to target self-harming behavior with clients in DBT. And Lars is a professor of psychiatry and suicidology at the University of Oslo. He is also the head of the Center for Suicide Research and Prevention at the University of Oslo. His work is focusing on suicide research, on prevention, on psychotherapy, and also on personality disorders. And his sort of onset start working with DBT was when he organized and conducted the first RCT in DBT for adolescents. And since then, he has been working and doing research, and he has also been very important in implementing DBT in Norway in a way that now in all regions of Norway, DBT is available for clients. Well, I think that could maybe be enough for an introduction, and I would hand over to you, Lars, for your presentation.
Well, thank you so much, Jan, and thank you for inviting me to this webinar this evening. I think this is really a good way of sharing knowledge and discussing important targets in our and challenges in our treatment with DBT. So the focus is, as you have already stated, self-harming behavior with clients in DBT and how to target it more effectively. And let me see, stating my disclosures. I do receive funding from different agencies for the research, but there is no funding for this presentation, and I have no financial or commercial conflict of interest to disclose.
Sorry to interrupt you, Lars. I think there's one thing maybe I forgot to mention, which is sort of the time structure and the possibility to participate also in this webinar. Our plan is to have Lars making a presentation for about 1 hour, and then we have another half an hour for discussions, and you are very welcome to participate in those discussions. If you want to do so, then the best way would be for you to write your questions into the comments on the YouTube page. And I will be following them, and I will be then handing them over to Lars in the last part of the webinar. Sorry, Lars, for this. I forgot this.
No problem. That's fine that we remember this because we really want to have some time for discussion. And this is the outline of what we are going to deal with today. First, a little background on the challenge of self-harming behavior. Not much, but still important concepts and also problems we deal with. And then we will go on to discussing some important things to target. For example, this very important target of attaining an earlier self-harm remission. I'm going to give you more meat on that bone in a moment, but this will be one point, and next will be steps in treating self-harming behavior in DBT directly and specifically. And then we need to, of course, have a brief section on how to respond to acute self-harming and suicidal behavior. And then finally, have some words on how to treat hopelessness. So that's the plan. So first, on the challenge and the background. So I'm sure all of you who attend this seminar or webinar, you know that one of the big predicaments in the treatment of people with borderline personality disorder or emotion dysregulation syndromes, you know that the suicide risk is high. Actually, 10 times the risk we find in the general population, according to good studies from many countries, for example, here in Denmark, as you can see in this reference. And we know also that lifetime risk of suicide in people with borderline personality disorder is very high if you look at clinical populations. Um, so we know that on average, people with personality disorder and the majority with cluster B disorders, they can, on average, expect to live 20 years shorter than the average person, which is a huge difference. So the standardized mortality rate for suicide is very high in people with these disorders, and perhaps contrary to what many people think, it is much higher, the standardized mortality rate in females than for males. Of course, males have more suicide, but for the diagnosis of borderline personality disorder, the difference it makes for the mortality is much larger in females than in males. Also, contrary to many people's beliefs, is that it is not among the youngest people with borderline personality disorder the risk of suicide is highest. It is actually in the people above the year 40 years of age. Um, so we have many studies showing these risk factors, and I'm not going to talk about suicide in this webinar. We are going to talk about self-harm, which is actually not the same. It is some overlap, but here are just clarifying some concepts. So suicidal behavior and suicide attempt here is self-harm with suicide intent present, while non-suicidal self-injury, which is going to be mostly what I'm going to focus on in this webinar, is self-harm with no suicide intent present. And of course, we know that there could be gray zones, and sometimes actually what starts as a non-suicidal self-injurious behavior can end up as a suicide attempt. This is how volatile it can sometimes be. But we better distinguish in principle between these different behaviors because they need different types of treatment. So we are going to focus mostly on non-suicidal self-injurious behavior, which is also most of what we see in our clients. And you can see here from studies that the majority of people with borderline personality disorder, they have both a history of suicide attempts and they have non-suicidal self-injury. So they have both, but these are from clinical and very selected studies, the three references I mentioned here. But we have an interesting study here back a few years ago where we actually mapped nearly all patients who were seen during a fortnight in one of the 107 out of 110 eligible outpatient clinics for adults in Norway. So that would be nearly all those clinics and nearly all those patients that were seen over those 2 weeks. And here you can see some interesting things. So people with personality disorders, and that would be mainly people with borderline personality disorder, they had not significantly more suicide attempts than people with other diagnoses, but they had significantly more NSSI behavior than almost all other diagnostic groups, and pretty much more too. So this is actually more of the speciality or the signature for people with borderline personality disorder is not suicide attempts, it is actually NSSI behavior. And therefore, their treatment needs should be also tailored even more around the NSSI behavior according to what I think, and we should be very clear about that. So now, how does self-NSSI behavior start? Well, there are some speculations and some empirical studies on this. This is from one of our empirical studies 2-3 years ago, where we actually brought in about 100 adolescents who all had repeated self-harming behavior and where we interviewed them at length on these issues. How did it start? When did it start? How long had it lasted? And these are some conclusions. So the earlier onset of NSSI behavior and the longer it has lasted, the more episodes you will have above what the longer duration could explain, and the higher the risk of an eventual suicide attempt will be. So these are some of those findings we think call for a very early detection program and active treatment of NSSI in young people. Of course, when you're treating adult patients, this is ancient history. You can't change the past for those patients, but you can certainly, and if you are one of those people who are actually treating young people, adolescents, this is a message for you. We should have an active screening policy, and we should have a very aggressive and active treatment policy, because as I hope to demonstrate for you during this talk, it really makes a difference if we can terminate or stop this behavior at an early stage. So that was a little bit of background, a little bit more on the background side. Of course, there are many ways of envisioning self-harming behavior or NSSI behavior. And in an emotion regulation perspective, at least, this could be how it looks. It's very simplified, but I think you will recognize some of the salient stages and elements in the explanation of how it works. So very often it starts with some prompting event. It could be on the internal arena, or it could be interpersonal or whatever it is. It very often leads to a strongly negative emotion, and particularly so for people who are more emotionally reactive. They react quicker and stronger, and they also have a tendency to not have brakes on. The self-invalidation that is so typically seen in emotionally dysregulated people facilitate actually a very strong negative emotion. And the same is with inhibition of emotions. Because if you are emotion phobic and you don't know what to do with emotions and you are not good at regulating emotions, what else to do and try to put the lid on the kettle? And well, that does not very often work so good. So it can lead to boiling over with a hyperarousal in all systems of the organism, with the body and emotion and the brain and cognition and many other things. And the cognitions will actually very often be very impeded, particularly a problem-solving capacity, the capacity to think clear, to make good judgment, and things like that will be actively closed down by the amygdala, and the projections from the limbic system to the prefrontal cortex will actually make cognitive functions be temporarily impeded. So that makes you even more vulnerable for the intense negative emotion to proceed. And of course, when people have discovered self-harming behavior as one way of regulating emotions, we know that this is very strongly negatively reinforced behavior. But also, it can also lead to many other negative feedback mechanisms, increasing this spinning wheel even more and making it becoming more and more rapidly evolving and also habitual behavior pattern. So that would be our model. And I show you this model because not because I don't think you know these facts, but I think we should show them to our patients. We should explain it in psychoeducation because it has a lot of relevance for the treatment and what we can do to change these behaviors instead of just letting it happen once again and again. We know also that individuals with emotion dysregulation linked to self-harm not only have a personal experience of emotion um, that is linked to emotion dysregulation, but also the recognition of emotion in others. So they are simply not good at reading people's faces or their emotions. And that, of course, can lead to a lot of transactional problems with other people. They also very often have extreme and negative and polarized views of other people, higher level of impulsivity, and they also have problems of knowing themselves intimately so that they perhaps trust their own judgment or value their own stance or self-validate when they feel bad. Stuff like that can lead to a lot of negative consequences. Also, they have a lack of social problem-solving skills, so making behaviors very often problem behaviors. And of course, all of the other extensive comorbidity with axis 1 disorders does not help a lot to the whole propagation of self-harming behavior. And from the perspective of therapists, very often it is challenging to treat self-harming people with borderline pathology simply because they come to treatment very often with negative expectations. Of course, that is not a rule without exceptions, thank God, but it can happen very often from experiences that person has from earlier in life with carers, from relatives, from friends or partners, or even from previous clinicians, that can create an even a more emphasized negative expectation. And that, of course, is not helping very much when it comes to that transaction that can become very highly aversive also to the therapist when you know you are assuming things from the other person and you are shaping the other person in a negative way. And the therapist might do the same the other way. And then you get it in a very intensified way and spinning out of control. So we also know that the risk of suicide, as I told you, and the risk of serious injury is, of course, creating challenges for therapists because they are afraid. They are afraid of losing the patient because they care for the patient. They are afraid out of many other reasons, also risks of litigation or harm to professional reputation and career. That can be real risks, and of course making more dire to treat. And all of these challenges could increase the risk of treatment failure, demoralization from both parties, not only from the patient but also from the therapist, and also burnout. So, what are these are the bad things. Of course, the good story is that this is according to a recent study from Melanie Harned and colleagues, where they actually looked at how suicidal and self-harming outcomes were predicted by the different behaviors in therapists. So what they, for example, here found was that the the better the therapist is to deliver DBT, the fewer suicide attempts the patient will have, the fewer hospitalizations, and the lower dropout rate. So the better we are to deliver treatment, the better it is going to work in terms of self-harming behaviors. Conversely, DBT therapists seems to be better at their best actually if they have people who are poorly functioning as patients and if they have patients with a high frequency of self-harm. And that was extremely interesting. So it seems that therapists, at least in DBT, are at their best when they are treating more self-harming and more dysfunctional patients. That's the good thing about it. I think we should be proud of this, and this creates a lot of hope. So now let's, on this background, go further into the different things we actually can do even better. And one of the things I wanted to highlight with you, and mind you, what I talk about here is both based on my clinical experience, but also a lot on my research. So it is research driven. And one first point is that attaining early self-harm remission is extremely important. So this is actually from a study we published only 1.5 years ago, where we looked at actually in 2 time intervals. And this is actually from the cohort Jan was referring to. These were the ones, these adolescents who we had treated with DBT or enhanced usual care. And in this study, we looked at the significance of whether or not the patient had had an early remission of self-harming behaviors. So, if the patient had stopped self-harming behavior within 1 year after the treatment, that would in the diagram mean 1.6 years after baseline. So, actually, those would be the early responders. And we compare them to the late responders who did not have this remission within 1 year after treatment. And what you can see here is that to be an early responder, that means that you have a mean of 60 episodes per patient, less self-harm episodes over a 3-year period. That is a lot of self-harming episodes. That's actually an enormous amount of suffering, but also of lost opportunities and chronifying behaviors in an early stage of life where you really need to learn more constructive ways of coping and mastering emotions and regulating emotions. So that was the one first message here. And then we have just recently, and this paper is just under review, we just recently have analyzed the data on how this worked when these adolescents went into adulthood. So on average, they were roughly around 30 years now when they were seen in our last follow-up. And mind you, 80% of the original sample participated in the last follow-up when they were around 30 years of age. And you can see the same pattern here, that DBT was associated with a lower frequency of self-harming behavior. But what I wanted to show you here is that if we looked at, again, that effect of the early remission of self-harm within 1 year after treatment end, we also now compared the adult emotion regulation capacity, and here measured through the DERS, which is a measure of emotion regulation capacity, as adults. So adolescents who had self-harm remission within 1 year post-treatment reported significantly less emotion dysregulation as adults. Think about that. That is actually very fascinating. There are many years between these measurements, but still, after all those years, and only after 19 weeks of treatment, actually there was a effect of this treatment and also of an early remission of self-harm. So it has long-term consequences, and I think it is really important that we acknowledge this because self-harm in itself has a pathological way of propagating pathological behaviors when it is ongoing. Much like, for example, substance abuse, instead of using constructive coping mechanisms or coping strategies, you continue with a pathological one. And that is not helping you, it is actually making you not only more suffering, but also more dysfunctional by the year. Okay, so I think that many clinicians, and actually including some DBT therapists, they believe that self-harming behavior will be reduced when other problems and symptoms become less severe. But then you forget that self-harm represents extremely strongly negatively reinforced behaviors, not easily given up. Actually, very often, our patients, they don't see the point because they see self-harming behavior as a solution to problems and not as problems in its own right. So when you eventually start giving up on self-harming behavior, patients should be made aware that they can count on abstinence symptoms. And those abstinence symptoms can take many forms. It could be an increased amount of thinking of self-harming, looking forward to self-harming behavior, planning self-harming, getting the means to self-harm, the razor blades, for example, urges to self-harm will increase, and escalation of symptoms triggering self-harming behavior, and so forth. And that often occurs when patients try to reduce self-harm, much like addiction abstinence symptoms. So I think we should make people aware and also plan for treating those abstinence symptoms. But actually, to focus then on the active and direct and specific treatment of self-harm early and try to attain remission, that was actually among the reasons why Marsha Linehan put these behaviors on the top of the treatment hierarchy many years ago, perhaps without having the firm data to support it, but the vast experience clinically to make that statement and make it very firm. So let's go a little bit further now into steps in targeting self-harming behavior in DBT. And you might think that I'm going to speak a lot about distress tolerance skills and stuff like that. These skills are extremely important, but I'm not going to talk much about it because one, I think you know them very well and you use them a lot with your clients. Actually, as a matter of fact, I think we are overusing them in the treatment of self-harming behavior. These are final and good resorts if you have no alternatives. But as therapists, I think we should think a little differently. So first, in your treatment and you're taking the first steps in the treatment of self-harming behavior, I think we should use even more psychoeducation about emotion dysregulation and the model of self-harm. So as I mentioned, this one, use it or some version of it, sit down with your patient and discuss it and see what you can make out of it in terms of finding targets to direct your attention. And that could, for example, be the negative reinforcement and the negative reinforcers to make a point out of that. And to also make the patient, your patient, even more aware of the forces you are up against because it's so strongly negatively reinforced. I think actually, when I think about the strong negative reinforcement of self-harming behavior, it makes me more compassionate. It makes me more empathic. I really feel strongly how terrible it must be to resist the urge of self-harm when that might be the only thing you trust, the only thing that really works. And then to skip it, very difficult. Therefore, we need to weave in, of course, that we have some other things that we can offer. We can not only offer the skills, but we can offer many more things that we can actually put into the equation so that we can actually make patients dare to trust us and to make decisions to change these behaviors. Also, use evidence from research, for example, what I showed you about the importance of reducing and stopping self-harm. I think that that is an illusion that you can always stop self-harming behavior and that you can stop it at any time. And it does not matter if I wait 1 year, or if I wait half a year or 3 months. No, it does matter. The longer you wait, the harder it gets to stop it. And particularly for young people, but at any stage, this is important to stop it very, very soon. And also you should psychoeducate about abstinence symptoms because these are real things. And I think you should call them abstinence symptoms because they will increase and they will become very problematic. And of course, you need to talk about skills and psychoeducate about skills. But then before you go any further, of course, as any good DBT therapist, you will do this. You will assess with the patient in a very collaborative way. You will sit down on the same side of the table with the patient and you would perhaps have a piece of paper before you, and you would hopefully, in a collaborative way, and hopefully let the patient write on the paper what would be my needs, what would be what I really need from you as a therapist. What do I need? What kind of help do I need? And of course, it could be many, many things on many different levels. I think we should try and help the patient define some life worth living related needs, something that can make the life more worth living, more worthwhile. And then, of course, link these needs to the goals. That could be something about uh, getting a job, getting out of treatment. It could be something about retaining a spousal relationship or getting a nourishing relationship, somebody who could love you, or it could be completing education, or something that actually very often problem behaviors will obstruct and get in the way of attaining. And therefore, we should always get the real needs of the patient, and that should be long-term or middle-term needs that you realistically could attain if you could remove the obstacles. And of course, the goals should always include reducing self-harming behaviors. And it's our job to help the patient see how self-harming behaviors will get in the way of reaching the quality of life or life worth living related goals. And that might sometimes be challenging, and it needs us, it requires us to often ask ourselves what is left out here and what is the kernel of truth in the patient's story. I've discovered many times very interesting and very surprising things. I think actually we are, if we are inquiring, have a stance of inquiry here, we are on the right track. But of course, we should also be exposing patients to the reality and not enter into wishful thinking. This is in many ways the essence of dialectics, and where dialectical behavioral therapy comes into its really good right. And of course, we need to, in the assessment of needs, also assess the patient's safety needs. So suicide risk here goes into the equation too. We're not discussing so much suicide in this webinar, but suicide is the backdrop as we started with. There's a real risk that the patient could take her own life. And since we don't want that, there could be some implications for the clinical management and patient safety. And I just wanted to mention the safety planning. I know that many of you are using it. It is an evidence-based intervention, very much in line with DBT. A lot of it is actually derived from DBT. Barbara Stanley and Greg Brown are the ones who developed this, and it's very, very, very commonly in use. Use some sort of safety plan and particularly use these elements. And that would be one step at least to increase safety while you are treating patients for their self-harming behavior. And this is also very well known for you. So if you are going to get anywhere with treating self-harming behavior, we need to be specific because this is behavior. It is not a behavior that coming out of the blue. It is caused by something and it has some consequences. So this is this classical way we are working with chain analysis with self-harming as the problem behavior, where we stepwise with the patient, we will analyze the problem behavior, focusing on all the aspects and environmental factors, including the triggering, prompting events, and consequences. So let's just look at one, we can call her Anne, one woman. Well, this could look like this for her. She is feeling this afternoon moody, tense, and restless, even more so than usual. But she is looking forward to see her friend. But then the friend cancels the appointment to spend time with Anna, and that turns out to become a prompting event because it leads very rapidly to Anne thinking she doesn't like me anymore. She doesn't want to be my friend anymore. And she feels sad, hurt, and angry. And that escalates more and more. And Anne has already had a lot of experience with using razor blades to cut, and it really calms her somewhat down. It becomes less unbearable for a moment, at least for a while. And then she calls her friend. And then the friend, after having talked to Anne for a while, she feels very bad, and she makes arrangements to reschedule their appointment. So this is a very common story, right? Not very complicated, but it is terrible for Anne. Once again, she has cut herself. Once again, she has been in a situation where she had the only way she could calm down was to use self-harm behavior. So I'm sure you can see many problems with this, but this is also something we can work on. So then, of course, I assume that you would already have tried to teach Anne some distress tolerance skills, but now I'm thinking more about how could you help Anne strengthen her emotion regulation capacity instead of just trying to calm down with using some distraction skills. Um, and one thing is, of course, to understand what is the emotion. So sometimes problematic emotions, such as anger, may be a secondary emotion used as an escape strategy to avoid intense primary emotions. We know that, right? And of course, to teach this to Anne, to discuss it with her, can help somewhat to increase her, let's say, mental health literacy or emotion regulation literacy, will help somewhat, but it will seldomly be enough to change behaviors. So starting to discuss it with her would be important, but not enough. What is needed here is exposure. Is often extremely effective, but also very often avoided by therapists. And that would be therapy interfering behavior, right? And probably the primary reason why we see this is that therapists don't want to expose or to make patients feeling even worse. They don't want to um, to, um, to present distressing material to patients. Very often try rather to soothe or to comfort instead of exposing. That is very understandable, but sadly not very effective. So what you could do instead would be, after having discussed with Anne, trying to identify with her the problem emotion. And therefore, you would need to do a microchain analysis, right? To try simply to find what is the problem emotion. And here, obviously, it ended up with being angry. That would be the problem emotion, right? Well, Um, and then, of course, you would actually also try to, with the patient, discuss, okay, you have now found that the problem emotion is anger. Well, what could actually be the primary emotion? What could be under this emotion of anger? What could be what really is going on, but that Anne is very quickly escaping? Well, I would think that one very good candidate here would be fear, fear of abandonment. That Anne would fear that her friend would not want to be with her anymore, not be her friend anymore, and as a matter of fact, that nobody in the end would want to be with her. And And for a human being to actually face that thought and that emotion, uh, that nobody would want to be with me, is actually pretty fundamental. It would, if you think about it, for most people, evoke a lot of fear. And once you have identified this primary emotion, you can ask the patient, okay, so this might be the primary emotion. That could be the one emotion that you very rapidly try to avoid and escape into anger. And then, of course, exposure would be the solution. So we could ask the patient, what do you think I would suggest we do if you suffered from insect phobia? If you have a fear of insects, and we think that that is irrational or not good for you to be so fearful of insects that you cannot even think about insects or look at a picture of insects, wouldn't it be a good thing for us to work on it? And exposure would probably be the answer. And most people actually, they know that it is possible to treat phobias with exposure. And then you need, of course, to discuss with the patient if the patient is willing to be exposed to that fearful emotion in this concrete example. And if the patient says yes, and you get the patient to be willing to try, you should, of course, validate the patient a lot. And then present the emotional cue to the patient. And that could look like many things. It could be, for example, to have the patient start describing how it would feel to be abandoned by her friend, or to be not having this person as a friend anymore, and the thought of perhaps nobody want to be my friend anymore. And then, of course, very quickly, we also need to block the escape behavior into the secondary emotion. And we also need to present the patient to a more skillful way, instead of escaping, of dealing with the fear. And in this case, it could be opposite action. To start, when the fear goes up, also entertain the thought that um, it is actually, it does not fit the fact of the situation, that just because my friend canceled our appointment, that means that she will not want to see me anymore. Does that resound much with her previous behavior? Is that how my friend really is? Or is it my mind now who is tricking me into a catastrophic interpretation of her behavior? So to go oscillating back and forth, to invite in the fearful emotion, but also blocking it, also block the escape behaviors, and also using opposite action as a more skillful way of dealing with that emotion. And then sustain this exposure until primary emotion is significantly reduced, and of course reinforce that behavior. And that would be what we would do in any such exposure session. And of course, that would be a huge step forward. And we should, of course, reflect with the patient what was achieved and how that can actually be used in the time interval between now and the next session, in the daily life, and how that can actually be generalized into patient's life. And of course, we need to repeat this time and again in several sessions. And I would say that for Anne, who had her primary emotion, fear of abandonment, which would prompt this runaway train into self-harming behavior, this would be one of the most promising ways we could work with her to help her regulate emotions in a more functional way, because the real fear of abandonment cannot be avoided. It needs to be faced, but it can also be regulated in a more functional way through opposite action, where you actually acknowledge the fear but not more fear than the facts of the situation will actually justify. So therefore, the patient can actually learn how to deal with fears or other emotions without using avoidance or escape into, for example, self-harming behavior. So back to the facts of the science. So if you look at some of the trials that have been published recently, over the recent years, we have seen that change in emotion regulation capacity is actually a mediator of the change in self-harm. So this is from the CARE study from the Linehan and Macaulay group in the US, where they had studied the 12-month remission of self-harm. And what would predict this? Of course, that would be associated very much with having received DBT. But that association between treatment and the remission was very much mediated through a change in emotion regulation capacity. So that would be a mechanism of change. So this is the empirical evidence, at least from this trial, that this, which I have said, is actually working very well. And I also wanted to remind you from Marsha's 2015 component study, treatment component study. And the point here is that if you want to treat have a significant effect on NSSI behavior, then you need to include skills training. Skills training seems to be indispensable when it comes to achieving NSSI remission. So, of course, skills here are many things. For example, emotion regulation skills, and not at all only distress tolerance skills. I would actually emphasize emotion regulation skills over distress tolerance skills. And here, of course, are some of the other good evidence for skills use as a mediator of change from both the study in 2010 from the Linehan group and several other groups have shown that DBT skills use is actually associated very much with reductions in self-harming behavior. And in the bottom here, you can see the study of Kranz. The mindfulness skill, acceptance without judgment, was actually one of the very distinct mindfulness skills that mediated the relationship between use of DBT skills and the change in frequency of NSSI behavior. And actually, I reviewed the different mechanisms of change in NSSI behavior just a few years ago. I think it was 3 years ago. And this acceptance without judgment skill was actually popping out in several studies that seems to have been very much studied, but also seems to be a very salient skill here when it comes to reducing NSSI behavior. So I wanted to actually talk a little bit about that. So what is acceptance without judgment? I might not need to explain that to you, but it is basically to rethink or rephrase our negative judgment in a form that is non-judgmental. So you will still express what happened, what you thought, and how you felt in that distressing situation, but without using words that express a negative and judging attitude. So, for example, here, in the case of Anne, just let's think how that could look for Anne. So what would she, for example, say about the situation when she felt sad, hurt, and angry? Well, she might have said something like this. She's such a bitch to cancel our appointment like that. I'm sure she hates me. Nobody likes me. That would be not uncommon for people who are emotionally upset to label their experience like this. So how could that be rephrased in a more non-judgmental way? Well, it could be looking like this. I was really disappointed when she canceled our appointment. It makes me afraid that she doesn't like me anymore and that nobody will like me. This is probably even more accurate, but notice that this is substantially less judgmental. But it also is more to the point when it comes to identifying what was really going on. She canceled our appointment, and that made me more disappointed. It made me disappointed, and it made me afraid that she doesn't like me and that nobody will like me. It's more succinct when it comes to actually describing what is really going on. And mindfulness skills are actually very helpful when it comes to more accurately describing what is going on in the moment in your life. And it makes it easier for you to know what to do with what is going on. Also, I would link some comments to this acceptance and change in facing suicidal ideation and urges to self-harm. And that is also something we should foster and work with in our client who are self-harming, the more non-judgmental way of thinking about this. So for example, here are some lines that you could actually suggest and work on with your clients. So, for example, self-harm urges are our way my brain is trying to regulate extremely distressing emotions. So it's actually pretty accurate. This is true, and it's non-judgmental. It's not, you see, many patients with self-harming behavior are very much ashamed of this self-harming behavior. They feel defective, they feel troublesome, they feel like losers, they want to hide it, and they judge themselves for being defective and non-functioning. Instead, this could be a more non-judgmental and more accurate way of describing what is going on. Or when I have a suicidal thought, I can use it as a cue to check with myself on what my brain seems to need to escape. Or when I have an urge to self-harm, I remind myself that I have strategies to cope with distressing emotions that are healthier for me to use. Or even, I'm proud that I am working on not letting self-harm control my life anymore. So these are still true, much more true actually, but they are non-judgmental and they are not fostering that shame and escape and need to hide and need to get away from the realizing that this is a real problem that needs to change, but it is not describing me as a defective and immoral person. It is much more compassionate, I would claim. And I strongly believe in all of these things. I would say hooray to my clients if they would achieve this truth and use it actively to think better of themselves. So I would think that we should also tell our patients and teach them that skills are actually intervening on many of these different stages in the runaway train of self-harm. It's putting on brakes. It is redefining the truth. It is making us think more constructively and compassionately about why we are doing what we are doing. But it's also making ourselves more hopeful, I would claim. So it's also making us more able to experience emotions and face the emotions because we have something we can do and we are supported by truth and evidence, but also by our therapists. So here are some more evidence from our studies on the use of coping strategies. And this is again from the long-term follow-up of these adolescents. They were adolescents, now they are adults. And this is how they used different coping strategies according to treatment conditions. DBT, as you can see, were much more associated with the majority of all of these different coping strategies. And many of them are actually very hopeful strategies that could actually make them more expecting that they would cope with these problems. And what we also found that having received DBT as a teenager, was significantly associated with not having suicidal ideation in adult life during a week where we used the ecological momentary assessment with smartphones. So we measured 6 times daily to what extent they had suicidal ideation and also how they used coping strategies. And also, having received DBT as an adolescent was significantly associated with an increased use of coping strategies, such as thinking that I can solve this problem and that I can cope with this in situation with negative emotions. And all of that was in real time. It was not self-report from 1 or 2 weeks past. It was actually here and now when I was facing negative emotions, what coping strategies did I use? And DBTA was actually associated in adult life with using much more functional and constructive coping strategies. I think this is fascinating. Okay, I think actually we can't just talk about self-harming behavior without paying a very, very few words on how to respond to acute self-harming and suicidal behavior. Since I think and I hope that many of you are DBT therapists, you know that we need to distinguish between these two forms of self-harming behavior, the NSSI and the really suicidal behavior. And here's the protocol for ongoing NSSI behavior. So if there is a risk of serious injury or death, and your patient calls you or communicates with you, or in session, it becomes evident that there is an acute risk of severe injury or death, you should, of course, assess or consult someone who can assess medical risk if you are not a medical doctor yourself. Or if there is a need of medical treatment, then, of course, get acute treatment for the patient. And if need is not acute, instruct patient to get herself necessary medical treatment. That would be our protocol if there is a really risk of serious injury or death. For adults, then cease further therapeutic contact the next 24 hours, not to risk reinforcing this kind of behavior. For some patients, that is pretty harsh, but this is part of the treatment arrangements and treatment contract. For adolescents, of course, we don't apply this 24-hour rule. So this would be for NSSI behavior, not suicidal. But sometimes it's not so clear. So for the telephone contact, for example, in a suicidal crisis, you know that this is our protocol. You need to ascertain where is the patient, who is she with, focus on the here and now. What prompted this crisis? Some interpersonal interchange, whatever it was. And is the crisis about suicidality? Then assess the immediate suicide risk. And then, according to the risk, of course, find solution. Of course, you need first to ask the patient empathically not to harm herself or take her own life. It may seem very self-evident, but this is important that you do this because patients sometimes get in doubt if it is best for everyone that she would be dead. We don't think so, so we need to say it. Patients can't read our minds. And you need to give advice, and this is the time to be very directive and concrete based on skills. Clarify and reinforce adaptive responses from the patient and get some adaptive responses, hopefully, and identify factors that can inhibit adaptive behavior. You need, if it's possible, to remove or reduce high-risk factors such as suicide means in the environment. And of course, also reduce ongoing high-risk behavior such as NSSI behavior or using drugs or substances. And of course, try and find a plan so the patient can commit to and troubleshoot that plan and assume that risk might reemerge, and of course reassess suicide risk at the end of the interaction. This is our protocol. And of course, you need to rehearse on this protocol. You if you are a DBT therapist, you will have actually been rehearsing this with your team members, because this is something we need to keep very clear and very, we need to be good at this. And of course, sometimes you should consider hospitalized patients. Very often you will not hospitalize, but some patients might need to be hospitalized. They have made suicide attempts, or they have plans of suicide with high suicide intent or the lethality. They might have signs of very severe depression or psychotic disorder. They might be having failure of impulse control. There might be few barriers against suicide. There could be few protective resources in the current situation and in the place where the patient is now residing. And it could be a situation in life where actually the patient is really, really destabilized. Now think about this, that patients with chronic self-harming behavior, there is no evidence that actually to hospitalize will prevent suicide. There is no specific treatment of patients with chronic suicidality that necessitates hospitalization. Actually, there are many don'ts here. It's a lot of good reasons why we should not hospitalize patients with recurrent self-harming behavior. Therefore, we should only hospitalize where there is no really other viable alternative. So I have just a few minutes left, and I wanted to end by discussing one of the things that I think we are underestimating, namely hopelessness. On the other side, hope. And this comes from my clinical experience, but also again from research. So this is from our 3-year follow-up of these adolescents. And here you can see actually one mediation analysis we did, and I'm going to explain this. So as you can see in the bottom there, treatment, if they had received DBT instead of enhanced usual care, that made a big difference, 3 years post-baseline, in the number of self-harming episodes during the second follow-up year, or the third follow-up year, I mean. So that was a clear direct effect. But then we studied whether or not it made a difference if we could attain a change in hopelessness feelings during the treatment. So only during this 19 weeks of treatment, there were reductions in some of the patients and some not, and that made a very big difference. So the change in hopelessness actually during the treatment mediated the association between treatment and the number of self-harm episodes in the long run, which is actually really important. And I wanted just to highlight some aspects of hopelessness. For people who are hopeless, very often feel stuck. They feel entrapped in a life situation where they have no control. They don't see any way they can make it better or worse. They simply are out of control, and they don't believe anymore that things can improve. They don't believe in improvement. That is actually the essence of hopelessness. No hope or expectations for any improvement of this terrible situation. And they cannot escape. They can't escape. Well, they can escape in one way, and that is to take their own life. But that's actually the main problem, that's the only way out. So what is the meaning of this? Well, in DBT, we have a lot to offer to combat and attack these 3 different components of hopelessness. So for example, we can actually show patients, for example, through teaching skills or teaching strategies they can use in their real life between sessions, that can make a difference, that can make them feel better, that can make them feel more in control of their life, their relationships, and many other things. That is one of the beauties of DBT, that it makes people get more tools to control their life gradually. They can also actually, we can use monitoring of through diary cards and through asking patients, in the early phase of the treatment, we can demonstrate that it actually makes a difference, that things can change, and that they are not stuck there forever, and that things can improve. And if it doesn't improve, then you will certainly want to know, and you will discuss it with the patient. And in itself, that will sometimes, very often, will actually um, pave the way for having more hope. Because once you have an opportunity to discuss with your therapist what can be made alterations to the treatment so that we can have more improvement, is another and a different approach than they have experienced in many previous treatments. And escape. Yes, there is escape, but not escape in the classical way. There is actually a way out of this hell, and actually that you are willing to climb out of this dark place with the patient. You cannot drag that patient out of the dark place, but you can climb with the patient. So actually, I want you to think more about hope, not in a philosophical way, but more like a cognitive skill. And this is not something I have invented. This is from Rand and Chevens from 2009. They postulated that hope can actually, or hopelessness can be defined as a lack of ability to produce pathways to achieve desired goals and to motivate yourself to use those pathways. And conversely, hope could be envisioned as a cognitive skill. And I strongly believe that. And I think in DBT, we should actually develop more ways of using it in DBT for promoting skillful behavior that can actually create this um, capacity to envision things that can happen in the future and that can bring me closer to my goals. So I think I've used my time now, and now we have the remaining time for questions or comments. And perhaps I should just stop sharing. Is that right, Jan?
Yes, I think you can, and the people can see us better. All right. Well, thank you very much. I think that was just a perfect combination. You had therapeutic concepts, you had a scientific background, and then you had also very clinical applications. I liked how you approached the topics from these different perspectives. So just if you are following us on YouTube, I just want to remind you that if you still have any questions that came up or want to participate, then feel free to put your comments and directly on the YouTube page, and I will be following that. So one question that reached me was actually from sort of the second part of your talk, and the request would be, you mentioned about how the therapist should manage contact after an attempt or let's say a self-harm behavior. And you said that there's this 24-hour rule for adults, but it does not apply for adolescents. So I was wondering, maybe you could comment a bit more on that rule for adolescents.
Yeah, well, the reason why we are using this rule for adults is that we, of course, when you're using telephone contact and allowing coaching with contact between sessions with patients who have this uh, behavior that they are hooked on, it is a real risk that you can reinforce that behavior. There is no question about it. And I'm not talking about people are trying to manipulate us at all. That is not my stance. I simply think very clearly that people who don't have anything else and they are desperate, they will very often use contact and sometimes also link their behavior to that contact. But for adolescents, I think for one thing, adolescents, they don't have that same control over their life. They are underage, they are minors, and we also need to know that they are not having the same possibilities. They don't have the same responsibilities for their own life. So I think it would be very risky for us and also unreasonable to demand that kind of rule for adolescents. I think that that is both out of on an empirical ground, but also an ethical stance. So I wholeheartedly believe in that. Also, I don't think the risk of reinforcement is we can work on that in different ways with adolescents, I think, than we can with adults.
Okay, yeah, I can see where you're coming from. I would then maybe want to jump to the sort of the beginning of your talk. It was one of the first things you were talking about, and there was this data that you were sharing about how good therapists are doing, what their results are. And one of the interesting insights was that I guess you were saying if the client is more severely dysregulated, then DBT therapists seem to be more effective. I wanted to ask you about this. Do you have any ideas what could be happening here?
Yeah, I think we don't know. This is just what they found, but they don't have any data on why this was. So I think there are several possibilities. One is that therapists are like, when they know something very well and they are up against a challenge, I think the challenge will bring out the best in us as therapists. We we know probably that is why I like so much to work with people with borderline personality disorder, because I have also I'm running other therapies too, other structured therapies that are very, very different. And I see the very big difference. And that is that with people with borderline personality disorder, there's never a boring session. Never a boring session. Of course, that implicates that I'm bored in other patient sessions, but well, possibly not. But I feel that I get to use all my skills and what I am. I really I'm put to the challenge. Um, I like that. And I think very many therapists, they like to be good. They like to do their best. That's why they became therapists. They, um, we therapists, we don't often get to have the same feeling as a surgeon, right? We go into the theater operation and we do our thing, and then we go out again after having saved the patient in just 1 hour. That's not what we experience. Our work is much more time consuming and it's not as clear cut. But when we see a challenge, I think we take it and we grow to the challenge. So that's my main explanation. And it could also be that, if a patient doesn't really need the treatment, we very often slide into eclectic approaches. I think so. I think if the need of the patient is not that desperate, I think we allow ourselves to slide much more easily than if we really see this is now it, and we need to use whatever we have at a high level. I think that is also one explanation. What do you think, Jan?
Well, yes, I mean, I agree with what you said. And then what I maybe also was thinking about was the target hierarchy. And I was thinking, well, I probably most DBT therapists know very well that if there's self-harming behavior, then that has to be prioritized. So that's very clear. Now I know what to focus on, and I'm trained what to do. But if I don't have that, if I have only therapy interfering behaviors or quality of life behaviors, which are in the lower, or comparatively in the lower categories, then maybe I will be more prone to changing from one behavior to the next. I won't stay long enough, maybe with the one behavior that I should focus on. And then, of course, if I change problem behaviors to focus, then, well, the changes we will achieve will be smaller because we haven't stuck with it for long enough.
Very true, very true. And of course, we know that's a general rule that it is much easier to treat overt behaviors and to treat positive behaviors
Mm.
than to treat absence of behaviors. That is actually not only for therapists, I think it is for everyone who is trying to change behaviors in the mammal. It's much easier if you have a very active creature that is having a lot of spontaneous behavior, then you can teach things very much more quickly.
Right, right. Okay, well, let me go back to the chat. I want to check that again. Yes, I do have some things that I can transfer to you. Let me see. Now, you can hear me, Lars, right?
Yeah.
Uh, well, this question is from Josephine. She asked, can thought about suicide be thought of as an NSSI? What are the differences to consider when treating suicidal thoughts?
Good question. Yeah, I think in principle, we can treat suicidal behavior in many ways the same way as we are treating NSSI behavior. Um, of course, I would say that I would first go for an analysis of the suicidal ideation. How severe is it? How problematic is it? How much time is consumed by thinking about suicide? Um, and if it is really a big clinical problem, I think it should be treated, and very often in the same way. It fits the same description in a way, but there is, of course, a big difference in some of the consequences. And for example, the reinforcement of thinking about suicide is not as strong. The negative reinforcement of thinking about suicide is not as strong as cutting. For example, you don't have the physiological reinforcement. You don't have these actually neurological things going on, but you certainly do have the cognitive and emotional escape effects, absolutely. And also, um, that is something I did not address. Um, but sometimes we should think a little bit about not removing too much of suicidal ideation. Because suicidal ideation can, for some person who have been thinking about suicide, can be a comfort. And if you don't have anything else to think about, for example, to think about suicide can actually help people not take their own life sometimes. That depends on the stage of the treatment you are in. In early stage, I wouldn't be very aggressive when it comes to removing suicidal ideation. But in the later stage of the treatment, I would definitely. If it remains a lot of suicidal ideation, I would be much more targeting that suicidal ideation. And we don't really know how much will remains, but in this adolescent study, we found that if you could actually have self-harm remission at an early stage, you would have significantly less suicidal ideation as adults, which I think is important. That you can actually remove suicidal ideation permanently with treatment.
Okay, yeah, thank you. Well, we can move to the next one. There's someone thanking you a lot for your talk, and this person is wondering if targeting self-harm behavior is different in patients with severe post-traumatic symptoms, dissociation, and the like.
Also a very good question. Thanks to Martin Bohus and colleagues, we do have now a treatment approach that it is possible for people who have both borderline symptomatology and PTSD to treat that simultaneously, because one of the problems before, in earlier days, was that uh, when you started to expose people because of the trauma, when you wanted, using the ADMA-FOA model of traumatic stress treatment, then that exposure could lead to an escalation of suicidal urges. And therefore, it was a predicament you didn't know where to start, for you didn't get anywhere with the PTSD symptoms without exposure. But exposure led to suicidal escalation. So, of course, one of the things is also that not only self-harming behavior is very strongly reinforced, but dissociation is very strongly reinforced. So this is a big, big problem. But lo and behold, for example, through this DBT PTSD model, ways have been found to expose patients in an outpatient treatment for the trauma, ad modum NAFOA, blocking dissociation by different techniques, but also working on suicidal urges, ad modum DBT. So that will be a whole new area for us to cover in the webinar. I think perhaps Martin Boas will speak on some of these things if he hasn't done that already. And that would be a specific treatment. So I would say there is hope. I don't think we should despair. I think that people who are having both PTSD and DBT, which many patients do have, they can receive effective treatment without risking becoming more suicidal.
Okay, yeah, thank you. I actually have one more question that I wanted to ask. You touched on this, but maybe you could elaborate a little more. One of the central features of the clinical example of Anne that you had was her being afraid, phobic of her fear of abandonment.
Mm.
And I really liked how you encouraged us to use exposure protocols to treat that. So I was wondering, maybe you could go a little bit deeper into the process. I mean, how to lead Anne towards that, how to set the cue for her to go into her fear together with her.
Right? Okay. So perhaps that would be easier if you and I could role play this. Is that okay with you?
Yeah, sure.
Would you be willing to be Anne?
Yeah, sure.
Okay. So let's say we start our role play when we have already decided that fear would be the primary emotion.
Mhm.
And so let's start with that, okay?
Mhm.
So Anne, I'm so glad that we were able to discover that actually anger wasn't really what was going on in your mind. It was fear. And I can so much understand how that fear would be intolerable for you. I mean, if I were to think that nobody would love me or nobody would want to be with me, I would probably also be very fearful. I can actually feel that emotion, a little ping of that right now. So thank you for sharing it. And but what I think we need to do, if we are going to get you to find other ways of dealing with that fear, you and I need to deal with it here and now in this session. I'm going to explain to you what that means, but do you think we could do that?
Well, it's just horrible when I feel like that. I don't know what do I need to do? I don't want to feel like that.
No, of course, of course. So what with people who have more simpler fears, like people who are fearful of insects, do you know anyone? Are you?
I know my sister is and my mom. Yeah, for me it's better. It's not so.
Okay, okay. So I'm glad that you aren't, but they are. And have you heard about exposure for phobias?
Oh, yeah, like when they do these spider trainings, you mean?
Yes,
That's what you
yes,
mean? Yeah.
exactly.
Mhm.
You heard about that?
Yeah, I
So
heard about that.
that would mean that people would be presented with pictures, for example, of spiders, and they would be even sometimes glasses where there are spiders inside them, and then they would be fearful. What have you heard about that? Have you heard about how that works?
Well, I think you just have to sort of be with that spider, and then, well, then it gets better after a while.
Exactly. That is totally the point. And I can imagine how fearful that would be for a person who hates a spider, that to be with the spider. Can you?
Well, yeah, I mean, they don't want to be there, I think.
No.
Yeah. And then
But
I
they
think they
can
have to
actually get
touch
over
it
it.
then later. Mm-hmm.
Exactly.
Mm.
So that's the point. So I was thinking that if you and I could do the same in this session, we can start and we can work on this in several sessions, but we can start now. And that would mean that I would encourage you to actually think more and talk a little bit more about how you were feeling and how you would feel now if you would think that your friend would not see you anymore. She would hate you. She would not want to be with you. Nobody actually would. That would be what it entails, that you talk about it. I would encourage you. How does that sound?
Well, when you started talking it, I mean, I already started getting cold and then warm. I
Right.
want to stop actually.
Yeah, exactly. And
Mm.
there are two things I think we should know before we start with this. One, that very quickly you could escape into some other emotion. For example, you could think about you getting angry at your friend, or it could be that you start having urges to self-harm.
Mm. Mm.
But the other thing I want you to know is that, remember we have been talking about opposite action?
Yes, yes, I do remember that. Mm-hmm.
Right. And one of the things that we ask ourselves is, does the emotion fit the facts? In the motion, in the situation, does it fit the facts? So what I would do while we are exposing you to this fear, I would ask you, do you think based on her previous behavior, how you know her, is he really going to leave you? Is that message you got last night,
Mm.
is it
Mm.
actually meaning that she will never see you again?
Well, yeah, that's true. That hasn't happened before. Maybe there's a break sometimes, but then, well, she always reappears or she responds if I. Mhm. Okay.
So it could mean that to feel that fear, that is very natural, but not at that high level. So what we could do is to use opposite action to regulate down that emotion, if you think so.
Mm-hmm.
So, okay, so do you get it? Is
Yeah,
that
yeah.
okay? So, Anne, could you tell me again how this felt when you were opening your phone and you saw that message? Tell me more about it.
Well, I thought, What's going on? Maybe she's leaving. She doesn't want to be my friend anymore." And then I was thinking of other people. I was starting to check, well, who's been inviting me or who's been postponing, and then I remembered Simona who also did this
Okay.
maybe 2 weeks ago, and then it was just overwhelming. I thought maybe there's more people even to come.
On a scale from 1 to 10, how high up are you now in fear?
8 maybe.
Okay, well, it's bad. Okay,
Mm.
okay. So, tell me more.
Well, what should I tell you now? Now just remembered all these people that might be reconsidering or not wanting to meet again. Being
Hmm.
friends, maybe not.
Hmm.
Hmm.
Are there any other emotions coming up? or is it fear?
Well, I was thinking about Simona, and I thought, well, she just doesn't put in enough effort, I think. She just
Mhm.
then she starts thinking about her family, and then she forgets me. It's not okay.
Can you
She
feel the
should,
anger now?
yeah, yeah, because I mean, she sometimes treats me like that.
So okay, so this is anger, and this is actually your escape from fear, back to fear.
Mm, mm.
Fear is the emotion we are after here. So you feel really fearful that you will be all alone,
Yeah, if this happens, I'll be desperate.
all right? So that nobody will be there for you.
Mm,
Okay. But could you
yeah.
now tell me, Anne, how likely is it that your friend who sent you that message will really abandon you based on her previous behavior?
Mm. She hasn't abandoned me before. I mean, she has disappeared maybe for some time. So I don't know, 10% maybe.
Okay, so it's not very likely based on previous behavior. It's not
Hmm.
really likely.
Well, that's
There
true.
is there is a small 10% likelihood. And that's enough for you to be a little afraid, right? Yeah.
Hmm. Hmm. Well, it would be very bad if that happens.
Yeah. How high up in emotion are you now in fear?
Oh, maybe six, something like that.
Okay.
Mhm.
So if something like that would happen, do you think you could do something? Is there something you could do if that 10% would happen and she would dump you?
I don't know, but maybe. I mean, I think who's left? Who else I can turn to?
Okay. So how did you get in contact with your friend?
Uh, for someone else? Well, I would write them.
Mhm.
I have two, maybe. Who can I can write to? And maybe I'll tell them a bit what happened.
So what you forgot right now was that you have some skills in how to make friends. So your friend who dumped or who canceled the appointment and is likely not going to abandon you, but if she does, you could make more friends in that catastrophic event that would actually happen.
Maybe, yeah, if I could get myself up and start writing, then
Okay.
yeah.
All right. I think we have to just stop here. Of course, in a real scenario, you would have had enormously more emotions, and you would have been a much more challenging. But you did a great job, and you allowed me, at least in principle, to demonstrate what I would say and what I would do. Um, what did you experience?
Um, well, of course, I had to try to think myself into the role. So I was busy with that. But as I was thinking, I was really getting tense also, and I was imagining that I wouldn't want to be thinking about this so much, how my friends are leaving me.
Mhm.
So I did feel that sort of looking for how can I stop this conversation.
Okay.
Mm.
Okay.
And then, but I did also feel that as we stayed, that it sort of wasn't as boiling anymore. That it actually,
Mhm.
I did get habituated somewhat.
So the idea is that we will work on this from session to session. You would adjust the exposure, you would develop it, you would take new situations, new emotions, and work on it. And hopefully, in the long run, patient will get less emotion phobic,
Mhm.
and there will be less escape behaviors. And you would cheerlead the patient. You would psychoeducate all the way and demonstrate what is happening and tell her how impressed you are, because you are impressed that you can really change such profound patterns of reactions and behaviors just with these measures and the willingness from the patient and from you to go into that work. because it also requires us to be willing to do it. It puts us on the spot, of course.
And it did really help that you gave me a lot of information about the process, and you gave me these fact-checking prompts, and then we thought about the worst case scenario, and you were sort of there staying very calmly, sort of you had this you were radiating this atmosphere that you know what you were doing. So I think that was also very helpful.
That's great. I think actually this is also creating some hope for people, that there is help to get some help, and I think it could be an okay message to close on, and that is that when we are doing this, we are also exposing ourselves, and we are extending
Mhm.
our limits beyond our comfort zone sometimes.
Mhm.
At the same time, we are getting better. And that's exactly what we are demanding from our patients.
Yeah.
So I think it's
Well, I guess I'm looking at the time. I think we need to leave it here. So I just want to take a minute to thank you very, very much again, Lars, for all you've given to us tonight. And thank you for answering those questions also, and maybe, and even including your role play for them practical experience. Thank you so much.
Thank you.
So bye-bye to everyone. Thank you for watching and joining us today.